Good morning, everyone. Good afternoon. Thanks for joining us. My name is Jeff Ladolter, and I'm filling in for our regular host, Steve Steiny, for this series, our Essential Substance Abuse Skills series. Today, we're going to be talking about HIV, STDs, prevention, and family communication. Before I hand it over to Dr. Garcia, I have a few slides that I want to cover for those of you who are new. This event is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center, which is located here at the University of Iowa, and we are part of a much broader national ATTC network. This project is supported by SAMHSA, the Substance Abuse and Mental Health Services Administration. The content is developed by our presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian and Alaska Native ATTC. At the end of today's event, I'm going to share the link to our evaluation survey in the chat box. The survey is important for our center. Oops, sorry about that. I think you lost me for a minute. Am I still screen sharing?
No, you have to reshare it.
Sorry, folks, almost finished. This 5-minute survey is important for our center, our funders, to make sure that our events are useful. Participation is voluntary, but we would really appreciate you taking just a few minutes to help us by completing this survey. You can skip any questions you want, and all responses will be kept confidential. And you can reach out to me or any members on our staff if you have questions. You're currently muted. Please use the chat box to make any comments or ask any questions, and we'll get to them throughout the presentation. Lastly, although we are gathered virtually today, we want to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 2 members of our team, Ella and Keely Driscoll. Our presenter today is Dr. Avis Garcia. She is an enrolled member of the Northern Arapaho tribe and affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. Dr. Garcia is a licensed professional counselor and addiction therapist and holds a doctorate in counselor education and supervision. And she specializes in addictions treatment and works with Native Americans. He works with patients of all ages and does individual, group, couples, and family therapy. He has more than 20 years of experience in the implementation and adaptation of evidence-based practices being introduced to Native communities, and we are lucky enough to have her as a presenter and senior consultant with our National ATTC Center. So with that, I think I will stop sharing and hand it over to Dr. Garcia.
Okay, I am ready to take it over. Good morning, good afternoon, everyone. Thank you for joining us today. Today, I will be talking about a subject that we don't talk about all too often, but it's very important with the people that we provide services to. And let me see, where is my slides? Okay, sorry. Okay. Someone usually covers these other slides too. It just talks about you'll be getting that survey after. I don't have any handouts for this presentation, but there is one website that I'll refer everyone to that has tons of valuable information. And okay, goals and objectives of today's presentation will be to cover the basics of HIV prevention, describe common sexually transmitted infections, explain the core components of communicable disease prevention, explain factors impacting the risk, and explain at least 2 strategies that substance use providers can use to prevent HIV, sexually transmitted infections, and other viral hepatitis. So the core competencies are to understand and describe the health and behavior problems related to substance use, including transmission, prevention of HIV and AIDS, tuberculosis, sexually transmitted diseases, hepatitis C, and other infectious diseases. Competency 105, describe principles and philosophy of prevention, treatment, and recovery. These align with the practice dimensions of 6 of SAMHSA's TAP 21. So on SAMHSA's website, you can download TAP 21, which covers all of the addiction counseling competencies. So that might be something you would want to look at. And we will move on to the next slide, the HIV statistics. The number of people living with HIV infection in the United States, the HIV prevalence is higher than ever before. About 1.2 million people in the United States were living with HIV at the end of 2019, according to the CDC in 2021. Of those people, about 13% do not know they are infected. Almost 50,000 new diagnoses are made each year. In 2019, 36,801 people received an HIV diagnosis in the United States. Consistent increases may be due to a higher proportion of people living with HIV infection knowing their status, surviving longer with antiretroviral treatment, and becoming infected with HIV than the number of people who die each year with HIV or AIDS. This here is a more updated diagram of the whole United States broken into the Midwest, the South, the West, and the Northeast. It breaks out the cases of AIDS, and like these in the Northeast, the urban population is all the blue on these rings here, the Midwest. These are all the urban areas of each area. And the suburban areas are in the yellow mustard color, and then the rural areas are the purple areas. So this is the South, the Midwest, the West, and the Northeast. So if you can see those areas, I think the smallest rural area is in the Northeast with 2%. So these are all the people that have been diagnosed with HIV in the United States in 2018, which is quite a lot. What is HIV and AIDS? HIV is an acronym for human immunodeficiency virus, which is the precursor to the acquired immunodeficiency syndrome, AIDS. HIV is the virus that attacks an individual's immune system and damages its ability to fight infection or disease. Once the immune system has been defeated, the individual develops AIDS. Right here, I have listed a website for you to get more information that I think is really helpful if you want to do more research. There is no current effective cure for HIV. However, with proper medical care and the use of the antiretroviral therapy, acronym ART, HIV can be controlled. Though HIV is not curable, ART medication can prolong the lives of those infected with HIV, lower the chances of transmitting the virus to others, and prevent progression to AIDS. If a client diagnosed with HIV is treated before the disease is far advanced, their lives can be significantly prolonged. So I remember, several years ago when AIDS was first reported, and basically at that time it was a death sentence. But thanks to all the technology and advanced medicine that we have, a lot of these people are living much longer lives. Okay, some of the routes of transmission. The most common is having sex without a barrier, no condom. Sharing previously used needles and works for drug users that inject substances. Almost eliminated in the United States is the occupational exposure and contaminated blood products. So these are people in the medical profession that are usually our doctors and our nurses, our frontline people that provide healthcare services. And then there is also the parent to child, which includes the prenatal and the breastfeeding. All require a direct exchange of bodily fluids from one bloodstream to another. To ease the mind of an unsure addiction counselor or other helping professionals, it's important to mention that HIV, AIDS, or other bloodborne pathogens cannot be transmitted by casual interaction with a client. This includes hugging, shaking hands, sitting next to one another, touching the same items. Again, transmission can only occur with a direct exchange of bodily fluids. And anal sex is riskier than vaginal sex, and sharing drug equipment such as needles with someone who also has HIV. Those are common transmission ways. Contraction of HIV/AIDS, again, the intravenous drug use, sharing infected needle to inject psychoactive substances. 2, sexual intercourse, unprotected sex with multiple partners or sex with prostitutes. From mother to child while in the womb or through breast milk. And blood transfusion. It's extremely rare, but it is possible. Extremely rare cases can be spread by having oral sex is extremely low. Receiving blood transfusions, blood products, or organ tissue transplants that are contaminated with HIV. Being bitten by someone with HIV. Contact with broken skin, wounds, or mucous membranes, and HIV-infected blood. Deep open mouth kissing, if both have sores or bleeding gums, gets into the bloodstream of the negative partner. Again, those are extremely rare cases. Blood transfusions, the risk is extremely small these days because of rigorous testing of US blood supply and donated organs and tissues. Being bitten, each of the very small number of documented cases has involved severe trauma with extensive tissue damage and the presence of blood. There is no risk of transmission if the skin is not broken. HIV is not spread through saliva. Eating food that has been pre-chewed by a person with HIV, the contamination occurs when infected blood from a caregiver's mouth mixes with the food while chewing. The only known cases are among infants. Again, extremely low. Some of the less common ways, which are from the mother to child during pregnancy, birth, or breastfeeding. Use of medicines have lowered the risk of mother to child transmission to 1% or less in the United States. So this is becoming a rare situation. Getting stuck with an HIV contaminated needle or other sharp object. This is a risk mainly for healthcare workers. And again, the risk is very low. They are doing a lot more in the medical profession to protect the workers. The sequence of events in HIV infection and acute infection lasts anywhere from several days to weeks is a viral transmission, which is marked by flu-like symptoms, sore throat, rash, night sweats, fever, and fatigue, and massive viremia. A symptomatic infection, it lasts anywhere from 2 to 12 years. So this could be a persistent, massive daily production of HIV, a gradual depletion of CD4 T cell population, and AIDS diagnosis, the CD4 T cell count drops below 200 for opportunistic infection. So people can have this for a long time and not even know that they are carrying it, which is important that people get tested. This is known as the treatment cascade. So if you look at the diagram on the left-hand side, those that are HIV infected, the highest number is over 1 million. And these are the number of individuals in the hundreds of thousands. So those that are diagnosed are 874,056. Those that are linked to HIV care are 655, some that are retained. And then there's the need antiretroviral therapy. There's 349,000 that people need that treatment. Some are on it. So there's more that need it than are actually on it. And there are a lot of federal grants out there now that people, organizations can apply for to obtain this treatment to give to patients. So this is usually for medical facilities or clinics. So just know that there is money that places need to apply for that. And then there's some that are adherent and undetectable. So there are some that, you know, we don't even know if they have it. And this is the numbers, as you can see, the cascade drops. At-risk populations, so these are those that are more at risk than the average person, which includes the gay men, the homosexual sex. Chances of exchanging bodily fluids increases dramatically. Minorities, especially those living in the inner city and are impoverished, infection rates are 6 times higher among African Americans and 3 times higher among Latinos. And this is due to the lack of public health resources and education available to these communities. So it is important to do education just like I'm doing today. Heterosexual women, unprotected sex with an HIV infected man, 8 times easier to infect a woman with HIV than vice versa. African American women who have sex with IV-used drug abusing men. So if they're sleeping with someone who uses IV drugs, that increases the risk. And then we have adolescents, age 15 to 24, represent the majority of new cases. This was very surprising to me as I was reading on the risky populations. And this is like a big thing for our adolescents and our young people to be aware that this is something that they could contract by not being careful or being educated. So creating an immediate need for education and prevention, and perhaps wishful thinking leads an individual to believe that HIV/AIDS is mostly contracted by irresponsible adults. Adolescents, just like their peers from other generations, adolescents are more likely to engage in risky behavior, especially if they're using drugs, without considering the possible consequences. Unfortunately, this behavior is causing a major epidemic among our youth. Treatment as prevention. Research has shown added values of art. This is the antiretroviral therapy. It reduces the viral load, which significantly decreases the likelihood of transmitting the virus. A person not living with the virus can take HIV medicines to protect themselves from infection. The viral load effect, getting or transmitting. So the viral load is the amount of HIV in the blood of someone who has HIV. Taking the HIV medicine, antiretroviral therapy, or ART, can make the viral load very low to almost undetectable. People taking ART daily as prescribed get and keep the load undetectable and no risk of transmitting through sex. So this medication is very beneficial. Ways that HIV cannot be spread is by air or water, mosquitoes, ticks, or insects, saliva, tears, or sweat that is not mixed with blood of a person with HIV, shaking hands, hugging, sharing toilets, sharing dishes, silverware, or drinking glasses, social kissing, drinking fountains, and other sexual activities that don't involve the exchange of body fluids, such as touching. I remember when HIV first came out, there was this huge fear of you couldn't be in the same room with someone that had AIDS. So it's no longer an issue. So when you're working with them, you don't want to treat them like they're, somebody that you don't want to get close to. This is also a new medication that's come out, and it's the acronym for it is PrEP. This is the pre-exposure prophylaxis. People who are HIV negative can prevent getting by using PrEP. And then there's also post-exposure prophylaxis, which is a way to prevent HIV infection after a recent possible exposure to the virus. So someone might find out that someone they had sex with might have AIDS and they're not sure. So if you can get this medication, it can help. Or for those that know they are going to engage, there is the pre-exposure. So this is all medical technology that's changing the healthcare. Linkage to care, structured programs to move people from diagnosis into stable care. So this is working through barriers, fears, and misconceptions, working through administrative barriers, and navigating environmental barriers, which also means evaluating available care options, working through insurance and affordability options, and LTC programs are not required for all people, but should be required for all programs. So wherever you are in the country out there, it is very beneficial to know what your community resources are so that if a client presents to you, you are able to help them get connected with care that they need. Sexually transmitted infections. Sexually transmitted infections are bacterial, which are the gonorrhea, chlamydia, and syphilis. These are all curable with antibiotics. The others are parasitic, which are the pubic lice, also known as crabs, and scabies, also curable with antiparasitics. The viral infections, the human papillomavirus, HPV, HIV, herpes simplex virus, and hepatitis A, B, and C. The viral ones are treatable, but not necessarily curable, but preventable. And there's antivirals. Hepatitis C, newly infected are either asymptomatic or have a mild clinical illness. HCV RNA can be detected in blood within 1 to 3 weeks after exposure. The average time from exposure to antibody to HCV seroconversion is 8 to 9 weeks. Chronic HCV infection develops in 70 to 85% of HCV infected persons. 60 to 70% of chronically infected persons develop evidence of active liver disease. Most infected persons remain unaware of their infection because they are not clinically ill. So someone, again, like with HIV, can have this for a long time and not even know. Again, important to get tested, especially those of us that work in substance abuse treatment. These are some new HCV regimens. So starting in 2013, there's Sovaldi and RBV, and these are all the different treatments that are given to treat that. Hepatitis C, the HCV co-infection, routine testing for HCV or any HIV positive person. So it's important for them to get tested all the time, which is currently available. Early diagnosis, evaluation, and treatment of HCV should be considered for HIV positive patients because HCV increases the hepatotoxicity on ART and may increase HIV progression, morbidity, and mortality. So not only having HIV positive, but if you also get hepatitis C in addition to, it can speed up the HIV progression and lead to mortality. So the HIV increases hepatitis C, viremia, can hinder diagnosis of HCV, increases HCV progression, mortality, and so either way, each of these has an effect on the individual. Hepatitis prevention opportunities in existing programs. All programs, clients need education, risk screening, and counseling. Hepatitis A, we can get vaccination. Hepatitis B, vaccination. Hepatitis C, we can do screening. Also counseling, referral, and some behavior change interventions. Prevention comes first. Intervention refers to the mechanisms and strategies used to operationalize or achieve a level of prevention. So what would you do to promote the idea of using condoms? Any ideas out there, those of you that are watching? I just recently moved from Cheyenne, Wyoming to Montana. I now work for the Crow tribe, where I am the director of their recovery program now. And one of the things I noticed as I was preparing for this presentation is I don't see any flyers around on sexually transmitted diseases. I don't see any condoms out. And when I lived in Cheyenne, we had the health department that would oftentimes just bring us bags of them. So we would put them out in the group rooms and put them, like even some at the front desk or even in the waiting room, just so that those are everywhere. And I would see the number of the condoms go down and we would have to fill them back up. So you need to be creative in getting those out there. Interventions are the opportunity to directly connect with individuals, communities, or systems that are creating or perpetuating risk in order to eliminate, reduce, or mediate the risk. Intervention always try to change something, especially if we're working with youth. They need to be aware of the risks that they could be taking. What is most effective in prevention is structural level intervention. These are policies and systems. Community level intervention is community level norms. So what are the norms in your community? Are we posting up any flyers, putting any information into the restrooms? Group level intervention. So this is individual behaviors through group settings. Are we talking about it in the schools? Are we talking about it in the treatment programs? This needs to be a part of the treatment programming at some point. Individual level intervention. So this is looking at the individual's behavior. So maybe pointing out to them, you know, when you're drinking, you know, you're putting yourself at risk in certain situations. And a lot of people that I've worked with in recovery have engaged in risky sexual behaviors for drugs. And they don't really come right out with that until they've been in recovery for a while. And when they start to get more honest, they open up and share a lot more. So it's good to be ready to talk to them about, you know, how has your life changed, and, you know, what's all going good in their life, so that they can continue to decrease the risk of their having any other problems. So which one do you choose? Examine your community and risk populations. So for those of you who are from all over, you want to sit back and take a look at your community. What is appropriate for them and the issue? Look to the science and what is effective and what is affordable. A cost-benefit analysis can help you to determine what may be the best. For example, on individual level interventions are expensive, but they are effective. Group level interventions reach more, but are marginally effective. community level interventions reach more people and take longer to affect change, but produce opportunities for lasting change. Structural level interventions can produce lasting change and can address root causes, social determinants, but are complex and often not supported with federal dollars. But like I said, there is some funding out there if you do some research. These programs can be expensive to conduct individual level interventions. So these should be reserved for your highest risk populations, which is your youth. You need to really hit your youth, the men having sex with men, and our communities of color. So the populations should be defined by their behaviors, the demographics, and undoubtedly risk is determined by social determinants of health. So it is important to get your message out there to those that need it so that you can do some prevention in your communities. One does not necessarily lead to another. High risk incident doesn't mean that it's an exposure. Exposure and transmission, transmission and infection versus spread. So it doesn't mean just because you were exposed, you're going to give it. Transmission doesn't mean you're going to get the infection. With proper treatment, you can have a long life. Remember, the risk of infection after an occupational incident is low. An incident will not necessarily result in an exposure. An exposure will not necessarily lead to the transmission of an organism. Even if transmission occurs, it may result in an infection. It may. Variables that increase the risk of transmission are covered in the next slides. Risk of HIV seroconversion, the average risk of HIV infection from all types of reported percutaneous exposure to HIV infected blood is approximately 0.3%. And the risk to HCP after mucous membranes exposure is about 0.09%. Okay, substance use treatment providers can conduct HIV, HCV, and STI prevention. Why substance use service providers? Because we have experience with behavior change professionally. We engage with high-risk clients on a daily basis, instill sense of accomplishment, self-improvement, and value of health seeking, and reduces the number of intravenous drug use occurrences with HIV risk behaviors under the influence. Service providers can be that link as they are more likely to be involved with these people on a day-to-day basis as counselors. Why substance use service providers? People living with HIV require HIV treatment and disease monitoring, but may be hesitant to access medical care systems. So they may be more likely to, once they build trust with someone within a treatment agency, to share more information with them. And when I work with people in recovery, I highly recommend that they go get a physical, because when people are using drugs and alcohol, they really aren't paying attention to their overall health care. So I often ask them to go get a physical early on. Sometimes these tests, I ask them to get blood work done and get the HIV test, get everything all checked out to see, what they need to start working on while they're in recovery and start learning to take better care of themselves. They may require consistent medical monitoring, if not for HIV. They could have other health conditions that they weren't aware of, such as diabetes or heart problems, you name it. So it's very important to encourage them to go get a physical. And they may not have insurance or know how to access care. So most of us that work with natives, we are fortunate to have the Indian health services in our areas, but not everyone has that. So again, knowing your communities and wherever you're at, I was in a rural area where after about a year, I was a lot more knowledgeable of other agencies that provided services for practically free to people that struggled financially to get medical care. So it's really good to be resourceful. And service providers can be the bridge to HIV care. And the last program I was at, we were able to obtain funding for those that had HIV AIDS, and it was called the Ryan White. So they were able to get all of the treatment for free. They didn't have to pay for anything that they needed because it was covered under that. Prevention as a core function. Prevention as a core function seeks to interpret the spread and perseverance of a condition. Substance abuse, sexually transmitted infections, and HIV can all be prevented. Prevention is a core function of public health and behavioral health practitioners. Historically, prevention efforts have tended to focus on primary and secondary prevention. This will continue to be the case with the sexually transmitted infections, but with HIV, the focus is turning to tertiary and secondary prevention, so treatment as prevention. The current prevention focus is behavioral and biomedical. So we are looking at, how can they change their behavior? And the biomedical is, there are medications out there that people can take to manage, again, the HIV, the sexually transmitted infections, but also I look at other health problems. So if we talk to them about their overall health, I think they're more open to go getting themselves tested. And one program that I worked for, they had like some incentives for people that would go get themselves tested for sexually transmitted infections and HIV. So sometimes, little things like that can encourage your clients to go get tested. Behavioral intervention involves examining the individual and the communal psychosocial components of behavior and implementing strategies to alter them. So we would be looking at their attitudes, what are their perceptions, what is their self-efficacy, what knowledge do they have, what are the norms in the area, and the perceived consequences, like what do they think could happen if, of the situations they may have gotten into while under the influence. These can be delivered through different interventions, again, one-on-one individually. We can cover this in a group, or we can address it in a community. So either way, all three of these needs to be covered to do some prevention in your communities. Biomedical involves the use of medical science to intervene in the biological and pathological operations of the virus or bacteria, which includes treatment, the PrEP and the PEP, and the microbiocides and circumcision. So these are all things that can be done medically to help prevent the spread. Combination of both behavioral and biomedical seems to be the most effective. So this is the EPT is the expedited partner therapy. So those are for people that choose to be in a relationship that they can both receive treatment for that. More testing, using the PrEP, and sticking to their medication. And their medication has to be taken daily and on a regular basis. So it's just like with any other, again, healthcare condition. If we got diabetes, if we've got high blood pressure, we start watching what we eat, taking our medication every day, checking our blood level, checking our blood pressure, checking blood sugar levels. So it's quite similar to that in managing one's self-care. Family roles. As a primary vehicle for socialization, families can, in the short term, create a social support network, foster access to healthcare. Maybe you want to make sure they get to their appointments and maybe be there for them when they go to their appointments. Modeling positive communication and behaviors, being supportive, avoiding hypocrisy, and provide opportunities for dialogue. Sometimes they want to talk to somebody. In the long term, to value open communication about personal issues, value norms around diversity, de-vilify sex, and combat gender norms. Family support is key to solving many problems that arise in today's society. When an individual is affected by illness or other problems, family members step in as the major support system. You can talk about environments of risk and how family and community moderate and mediate risks for disease and substance use. To date, response to the epidemic have been largely individualistic, bypassing families. The notion of families has been revolutionized. Families now extend beyond biology, religion, and gender, and law, and to reflect the intimate social groups on which all human beings depend on for their survival. Families that carry the heaviest load in treating, caring for, and protecting children and other members directly affected by the epidemic play a fundamental but not as yet fully recognized role in the prevention of HIV transmission. Families are also important for especially marginalized groups. The children are amongst the most stigmatized and underserviced in the world, and family networks are frequently the last bastion of support for individuals, especially in marginalized groups. Attention to families extends to AIDS prevention, treatment, care, and support from the individual to social groups, as it should always have been. One example that I was listening to the other day was a mother who had HIV, and her daughter had taken the calendar, and every time her mom would take her medication that day, she would put a star on the calendar. And her mother had asked her why was she doing that? Why was she marking up the calendar? And she said, well, every time you take your medication, Mom, I keep track of it so that we know you're taking your medication every day. And so this lady's, the viral load level was checked on her HIV, and they were like, you know, it's really low, it's really good, you're looking really good, you're really healthy. What are you doing that keeps you taking your medication? And she shared that, you know, it was just something as simple as her daughter marking a star on the calendar for every day she saw her mom take her medication. So it's simple things like that. You know, a lot of people tend to think, you know, it's not my problem, they can take care of that themselves, or, you know, they need to do it themselves. Well, everybody, you know, our families need to be there to help each other. Some community roles. Communities have a responsibility to establish resources and access to resources for HIV and substance use. Create social policies that emphasize health, wellness, equal access, and disallows discrimination. Communities have opportunities to shape norms around sex, drug use, risk reduction, harm reduction, and gender. Encourage sexual and substance use education in schools. Create policies and syringe service programs and safer injection facilities. Community is at the micro level. Access to resources include through social welfare and through physical issues like geography and transportation. System roles are the mechanisms through which formal services are delivered. Understand community needs, align services to community needs and community culture, work to alter potentially harmful community norms, ensure access to services, design and provide services through health equity lens, provide the list of prevention services, modify systems to accept a variety of insurance carriers. The community viral load. This is modern prevention with thought and science. Look at the community as if it was an individual person. Just like a person has a viral load, the community can have the same. Look at the sheer prevalence of HIV. So if you stop and take a look at your community, I know I come from the Wind River Reservation in Wyoming, and I do know that there are people there that have been diagnosed with HIV. And I think our community, not to violate privacy, but we need to be aware that the risk is there. It is in our community. And looking at the community's viral load, which means what are we looking at to prevent that? How are we getting this information to our youth? These are the ones who, like I said, this is the majority of the new cases in the last few years, is that age 15 to 24 range. So this is our young people that are getting AIDS at higher rates than ever before. What can be done to lower a community's overall viral load? Prevention, 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 and treatment. We can still prevent the transmission of it, the spreading, the spreading of it, and the treatment can also prolong people's lives that are dealing with these issues. So the community, we need to take a better look at our communities. What can a substance use provider do? Clinical and individual. Include indicators for HIV, STIs, and HCV risk in all assessments. So when you do your assessments, are you checking for HIV? Have they been tested? Sexually transmitted infections, again, have they been tested? And for hepatitis C, are we checking for all of those? I know we have to have them get the hepatitis test when we're sending them to treatment, but if you can get all of these done and encourage them, and I present it as, hey, when's the last time you had a physical? When's the last time you had your teeth checked? Things that they can do for themselves, and really encourage them to focus on their health. Include actionable items on HIV, STI, and or HCV in all treatment and service plans. So if this is something that they're dealing with, put that in the treatment plan. We want to make sure that we're helping them to improve their health condition. Include families and partners in counseling sessions to discuss risk and provide education. Key into what environmental and social factors contribute to not just drug use risk, but also sexual health risk. Become involved with Ryan White case management care teams. The clinical and individual, we need to conduct HIV, STI, and viral hepatitis screening and vaccinations. And you can refer them to your nearest clinic for that. Some people have the public health centers that do these as well. Provide referrals and assist with medical linkage to those living with HIV or HCV, and discuss medication adherence as part of clinical practice. And practice basic HIV and STI education with your clients. So a lot of times when I get young people, I'm always talking to them about these risks that are out there and what are they doing to protect themselves, not just from diseases, but teen pregnancy is also something that we want to prevent with our youth. What can a substance use provider do? Environmental, create an environment where it's okay to discuss sexual behaviors and identities. And I come from a culture where I grew up where these were taboo topics, being raised by my grandparents. I was always told that this is something you don't go and talk about. And now with everything that is going on in the world, I really feel that it is important to get that information out there, especially to the populations that we're working with that are at a higher risk than others. Serve as a conduit for information for individuals and families. So what you learned here today, you can take it home and share it with your family, and talk to your kids and other people that people that are in treatment. make condoms available. Like I said, you can get them free from most public health agencies and put them where they're available. Programming that makes syringes more accessible to high-risk users. So these are mostly in the inner city areas where they do run these programs for people that are IV drug users to get clean needles to lower the risk. Integration, substance abuse treatment and prevention with HIV and STI prevention. So we do need to put these together. Substance use screening with HIV, STI risk screening, HIV prevention and treatment. So this is adding that component to substance abuse treatment. We're always talking about, we're treating the drug and alcohol problem. Oh, they have trauma, or they have depression, or they have anxiety. What about HIV and sexually transmitted infections? We also need to address that. Make that a part of their treatment, make it a part of your programming, make sure you're educating your clients on a regular basis about the risks of sexually transmitted infections. One therapeutic intervention discussed in working with this issue is preventive services. Being solution focused with active drug users utilizes a positive service delivery model. Uses a strengths-based approach, collaborate with the client and write down strengths as a way to empower. Address overlapping, intersecting, and co-occurring disorders and diagnoses. Conveys authentic interest, mindfulness. Acknowledges and provides support for positive steps already made. For example, scheduling an intake appointment, scheduling a test, client identified needs. So, you know, when they start to take those steps to take care of themselves, every time I work with a client, even in a group setting, I always ask them, what one thing are you going to do to improve your recovery? And, you know, I have everybody tell me one thing they're going to do if they're going to go and get their physical, or especially on an individual basis. So really support them in making that decision and encouraging them when they follow through. Advocate for them, frontline perspective. These are emerging trends. So we also need to advocate for our people in our communities. And also this supports environmental change. The more people we get to be engaged in taking care of their health is making that change in your community as well. Okay, looking at the time here, I guess I can open this up for some questions or comments. Any questions, comments from anyone?
No, I just
I
wanted to say I appreciated your presentation, and working in the tribal community up here at Tule River. You know, it's something that we haven't put out there a lot, and I work with the youth program, and I've been putting some information regarding this out there in the community, and also, you know, started putting the baskets with the condoms available and that sort of thing. And so I know it's something that's really important to get back out there, and I'm going to put an order in for some more condoms because we ran out. But
Yes.
Yeah, it does really need to be talked about, you know.
Mhm.
Thank you.
You're welcome. I'm glad you're doing that. That's very important. Some people tend to think I'm promoting our youth going out there and engaging in sex. And I'm like, they're going to do it regardless. You know, I even talk to them about a birth control, you know, the young girls. I tell them, you don't need to have your parent, you know, if, you know, you want to protect yourself. And I tell them, you know, I was not raised that way, but going to college, I compared myself to my peers that I was going to college with. And, you know, I'm, you know, being the only Native American usually in most of my classes, was I saw all of these college students, these young women, they didn't have no kids and they weren't married. They were really focused on their career. You know, they wanted to get their education. And I was like, mine was a little bit backwards. I already had my family, you know, so I always looked at those differences. And so I let these young people know, I want you to, you know, achieve these things in your life, and having, you know, kids at a young age is going to be something that's going to hold you back from that. So that's just something that I put out there. And that's because I love working with youth, and that is the group of people that we need to really put prevention efforts in. So those of you that are, you know, encouraging them and supporting them, that is really awesome.
From the chat, there's a question. Have you seen any connection to the birth control implants with an increase in depression and suicidal ideation among adolescent girls?
Mm-hmm. That is a really interesting question. I honestly haven't. And this is the implants. No, I haven't heard anything about it. This is the first I'm hearing, and that's a really good question. And to be honest with you, I don't know anything about that, but I'm writing this down because I will definitely be looking it up. I do know that that was a popular birth control method that I seen a lot on the reservation where I am from. Let's see if I can't do a Google on my other computer here. Any other questions out there?
One member asked if there's a website that you know about that deals with talking with youth under 18 years of age about sex and birth control or prevention.
There is a site, as I was doing my research for this presentation, and it is called hiv.gov. Very simple site to look up. And if you do some like researching into it, you can find a lot of presentations and curriculums that are already done in there. There is also one that I didn't get time to look at. It's on natives. It's strictly made for Native Americans. It's a Native American presentation, and I plan to go back in there and pull that one out so that I might be able to use that with my groups where I'm working now, or get my staff to use it with our groups. And we are also required to at some point cover this very topic today. So my staff will probably get the same presentation that I did here today with you guys. But yeah, hiv.gov, full of very, very, very good information. That's where I got a lot of the stuff that's on here today. I think if there was another one. The CDC has some good information too, but I liked the hiv.gov the best.
I had just talked to our head nurse at our clinic, and she recommended the implant for the teens 15 to you know, before pre-sex. That's what she recommended.
Was the implant?
Yes,
Okay.
it's the implant. It's 3 months every 3 months an injection.
Okay. Yeah, I am reading birth control pills can triple your risk of suicide. It just says a study says. I'm trying to see if I can find something on the actual implant itself. That is interesting. That
Hi, this is Andrea from Hopi Behavioral Health. I was the one that made that comment. We have repeatedly brought that concern up with our local IHS, but it's not received very well. But so we're trying to keep a better track of the individuals that are coming in shortly after they either receive the Nexplanon or Implanon, that their depression has really increased. It's also their thoughts of suicide ideation has increased. We have good medical providers. We have a teen clinic in our local high school, but my concern is just about every one of the youth that I have contact with, they have been given the Nexplanon or Implanon, and we see them in the ER. And I just have really strong concerns about that. You know, I know parents, about half of them parents don't know. And the explanation from the medical provider is that, you know, we do have the highest rates of teen pregnancy in the county. STI rates are really high. She's said publicly that she doesn't want the teens having children and they end up in social services, but I just have really mixed feelings and reactions with her comments.
I'm reading right now, I Googled and it says Nexplanon, some frequent side effects are mood swings, weight gain, headache, acne, and depressed mood. So, you know, if you hadn't brought this up at all, I wouldn't have even been aware of this myself. So that is something pretty serious. And if that's the implant, then why aren't they using something else? You know what I mean? Like other birth control pills.
I know that when I was 15, my mom, she literally, that was like her only option. That was like, as soon as the doctors mentioned it, they said it was 3 years. And she was like, awesome, great, sign her up for it. And then it took me 2 years to even come off of it because like my body was so used to having hormones shot into it that I wasn't even able to like have a normal cycle or anything like that for 2 years after it had come out of my arm. So they thought that I wouldn't even be able to have kids at that point. So yeah, it's pretty intense. And I had to come off of it because of mood swings and depression. So.
Thank you for validating my concerns.
No problem.
One more question from the chat. Which gender is this more prevalent with in Native communities?
The HIV?
Yeah, I believe that.
I believe that I read it was the female gender.
I just had something to say about the Nexplanon. I work in White Earth, Minnesota. I'm a therapist, and I've had at least two kiddos that I worked with, teenagers, that had recently gotten that put in, the implant put in, that were having sudden changes in their mood and depression, and they didn't know why. And they just suddenly became really dissatisfied with life and were really depressed. And I recommended them to both have it removed. And when it was removed, their mood improved quite a bit and the depression decreased significantly.
That's interesting. Yeah, I wasn't even aware of that until now. And someone who talks to youth and you know, people in treatment about birth control, this is something that I needed to be aware of. So I learned from you guys too. It's not just me giving information. I was Googling the American Indian, Alaska Native people with AIDS, and actually the highest rate is the male to male sexual contact is higher than the female. Of all the cases that there are, 75% of those transmissions are male to male sexual contact. And then the women's is about 57%. So that's heterosexual contact. And so that's with just the female, her having contact with a male. So that's, so I said wrong when I look at the CDC. CDC is full of very good information. It also has injection drug use for women. HIV contact is 43%. So a lot of that for women is through IV drug use. Yeah. Thank you, Ray. That's very true. There's been some medications I myself stopped taking once I realized there were some side effects to it. And I think it was this summer, I had a very bad reaction to a medication that I was taking, and I wasn't even aware of it, but I would notice I would start to feel better when I didn't take it. So I was getting to where I didn't want to take it. And once I went to my doctor, they confirmed I was having like a serious reaction to the medication. So they had to wean me off of it. It wasn't one of those medications I could just stop taking. So, but I was so glad to get off of it.
Do you have any more questions for Dr. Garcia?
Everybody's pretty quiet.
I have a question.
Go ahead.
I was wondering about like getting parent buy-in for like educating youth about sexual activity, STIs. I find that youth can be pretty eager to learn about it, but there's some resistance from parents.
I used to work with kids as a school counselor, and ironically, I had to send the notes home to all the parents, letting them know that I was having someone come in and talk. And all of the parents, I would say 99% of them signed the permission form, and the one parent that didn't want her son to participate is the one that went out and got someone pregnant while we were still in the school program. I was like, you know, not to criticize her, but parents have their own choice. I think it's very important to, my response was really good. Like I said, about 99% of the parents happily signed the form and got permission. So that would be one way. I mean, you might even want to put this information on there, like these kids are at the highest risk category, like the largest percentage of new reported HIV cases is of age 15 to 24. Put some factual data on there that's going to get their attention, you know. And we want to educate your child, and a lot of parents don't want to have that conversation with their kids anyway. So, oh, cool. Somebody just shared a very nice link for Healthy Native Youth. Awesome. Thank you. I'm going to copy that one down. I like that. Thank you, Michelle. Okay, Jeff was reminding everyone to fill out the GIPRA survey. It's just a few simple questions that we have to have for our data that we collect on all of the presentations that we do on here. Next week, I will be wrapping up the trauma series that I've been going over for the last 5 months, and I will be covering intergenerational trauma, and it's linked to substance abuse. So those of you that are following that series, I'll be up on that next week. Thank you, everyone, for taking time out of your busy schedules today. When I see people like you attending these types of trainings, it makes me feel good because I know you care about yourself and the people that you work with, that you want to learn. And I always tell people, you know, today is something very important that we don't always talk about, that, you know, go home and talk about it with your family and share this information.
Thank you very much, Dr. Garcia, and for all the attendees. I'll keep the room open just for a few more minutes in case anyone wants to look at the resources that Michelle hopefully posted in the chat.
Okay.
Thanks, everyone.
Thank you so much, Dr. Garcia. This is Michelle Singer. I'm citizen of the Navajo Nation, and I work with the Northwest Portland Area Indian Health Board. And we do have, we certainly appreciate this topic and so grateful that this is being addressed. We do have culturally appropriate curricula around the topics of HIV, STD, STIs, consent, all under Healthy Native Youth. And then we also have our wearenative.org, which is for Native youth by Native youth. And these topics are also addressed in a way that's culturally appropriate and relevant, and with humor, which our youth like, you know, that needs to be, which has that lens. And so we encourage folks to take that. But the parent aspect and caring adult is so important. And it's unfortunate that kind of the Western dominant way has made it taboo to talk about sensitive topics with our young people. It's almost like we forgot how, even though it's in our stories, it's in our teachings, it's in our rites of passage. So we just try to bring out that aspect in developing resources and tools in this way. But we will be focusing on HIV, STI reduction within those priority areas that you laid out, men having sex with men, IUD users, 18 to 24-year-olds, where we're seeing high rates happening amongst young people now, and encouraging testing, prevention, and treatment. So we look forward to more of this topic amongst this particular forum. So thank you for bringing attention to this today.
I'm glad you were here today to share your valuable resources with everyone that's here. I've definitely made note of it, and I will be sharing it with my prevention person on that's at my program where I'm at now. And I will definitely be logging on there and checking it out. That this is a much needed area that we need to focus our prevention efforts on. I attended a conference on sexually transmitted diseases and HIV before the pandemic, and I was just, shocked to hear what some of the trends are with our youth as far as engaging in sex and swapping partners and having sex parties. And I was like, oh my God, I'm glad my kids are all past the teenage years now, because I would be very, very worried if I was a parent of a teenager right now.
It is, and so that's why we utilize quite a bit text messaging, because people can get private confidential text messaging, either tips, coaching, to encourage reaching out for help or testing or even education. So yeah, I will put the link. We have a newsletter, we have text messaging, a community of practice as well. So we thank you again for drawing attention to such an important issue.
Thank you.
All right, thank you, everyone. Have a good Wednesday.